Welcome to this rapid-fire explainer. If you're a focused learner looking to master critical care and shock concepts quickly and efficiently, well, you're in exactly the right place. Today, we're hammering through a high-yield, rapid-fire format designed to test your knowledge, clarify complex physiology, and arm you with the crucial exam pearls you need. We're skipping the fluff, so let's get straight into the heavy-hitting clinical scenarios.
Okay, let's dive into this. We've got 10 incredibly high-yield multiple-choice questions focused strictly on shock and perfusion. We'll break down the right answers and exactly why the wrong options are incorrect.
Blood pressure in adults falls after how much percentage of circulating volume has been lost? The options are A, 10 to 15%, B, 15 to 20%, C, 20 to 25%, D, 25 to 30%, or E, 30 to 40%. The correct answer? It's E, 30 to 40%. You see, adults have incredible compensatory mechanisms like vasoconstriction and an increased heart rate that literally maintain your blood pressure until a massive 30 to 40% of circulating blood volume has already been lost. Let's hit some hemorrhage exam pearls. Adult blood pressure usually falls after that 30 to 40% mark. Children, on the other hand, maintain their blood pressure until very late in shock. This means hypotension is a notoriously late sign of hemorrhage. Tachycardia? That's your much earlier indicator. Remember, shock might already be severe despite a totally normal blood pressure reading initially.
A septic shock patient remains hypotensive despite adequate fluid resuscitation and a CVP of 15 millimeters of mercury. Which therapy is indicated? A. Intubation. B. Recombinant activated protein C. C. Epinephrine. D. Norepinephrine. Or E. Dobutamine. The correct answer is D. Norepinephrine. Persistent hypotension despite plenty of fluids tells us we're dealing with vasodilatory septic shock. You absolutely need to clamp those vessels down, and norepinephrine is your clear first-line vasopressor here.
Target mean arterial pressure, or MAP, must be greater than or equal to 65 millimeters of mercury. Norepinephrine is the first-line vasopressor. You want to give 30 milliliters per kilogram of crystalloid fluid initially. Always draw blood cultures before giving antibiotics, get early source control, and reach for dobutamine if the cardiac output remains inadequate.
A diabetic patient with a recent myocardial infarction sustains a 20% thermal burn. What's the best monitoring method? A. Hourly urine output. B. Swan-Ganz catheter. C. Central venous pressure. D. ECG monitoring. Or E. None of the above. The correct answer is B. The Swan-Ganz catheter. Because this patient has significant underlying cardiac disease, that recent MI. They require highly detailed hemodynamic monitoring that basic tools just can't provide.
Here are your Swan-Ganz catheter exam pearls. It measures the cardiac index. It provides an accurate assessment of preload. Plus, it measures mixed venous oxygen saturation. It's far more accurate than CVP in critically ill patients, which makes it incredibly useful in cardiogenic and complex shock states, where you simply can't just guess what the heart is doing. In which type of shock is mixed venous oxygen saturation, or SVO2, increased above normal? A. Hypovolemic shock. B. Septic shock. C. Neurogenic shock. D. Spinal shock. E. Anaphylactic shock. The correct answer is B. Septic shock. Now, why is that? Well, in septic shock, there's severe microcirculatory dysfunction and shunting. The tissues literally cannot extract the oxygen effectively, so the venous blood returns to the heart, still carrying a higher than normal oxygen content. The crucial metric to remember here is greater than 70%. Normal mixed venous oxygen saturation is between 50 and 70%. Septic shock usually shows an SVO2 greater than 70%. Compare that directly to hypovolemic or cardiogenic shock, which cause a low SVO2 because the tissues are desperately extracting every drop of oxygen they can. A high SVO2 always reflects impaired tissue oxygen extraction. What is the best available option to assess gastrointestinal tract perfusion in septic shock? A. Base deficit levels. B. ABG assessment. C. Urine output. D. Mixed venous oxygen saturation. E. Regular bowel sound assessment. The correct answer is D. Mixed venous oxygen saturation. While direct gut monitoring methods do exist, among the standard clinical options, SVO2 is the best indicator of global tissue perfusion. So the crucial point is this. Direct gut perfusion methods include sublingual capnometry, gut mucosal pH, and laser Doppler fluorometry. Mixed venous oxygen saturation reflects global oxygen delivery, so a low SVO2 suggests inadequate oxygen delivery. Ensuring actual tissue perfusion is vastly more important than just treating a blood pressure number.
In which of the following types of shock is the use of inotropes as first-line therapy not justified? A. Hypovolemic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Septic shock. E. None of the above. The correct answer is A. Hypovolemic shock. The primary problem here is an empty tank, literally reduced intravascular volume. If you give inotropes to squeeze an empty heart before restoring volume, you're going to worsen tissue perfusion and aggressively spike myocardial oxygen demand.
Hypovolemic shock pearls. The absolute first-line treatment is fluid resuscitation. Using inotropes without adequate preload is physiologically harmful. If you use early inotropes here, coronary perfusion decreases while myocardial oxygen consumption dramatically increases. Always restore circulating volume before reaching for vasopressors or inotropes.
A spinal trauma patient presents with an initial pulse of 62 and a blood pressure of 70/50. After 2 liters of fluids, the pulse is 70 and blood pressure is 100/65. Most likely diagnosis: A. Hypovolemic. B. Septic. C. Neurogenic. D. Spinal. E. Anaphylactic. The correct answer is C. Neurogenic shock. This occurs due to a loss of sympathetic tone after spinal cord injury, leaving you with unopposed vagal activity. And this brilliantly illustrates neurogenic shock, which presents with hypotension coupled with bradycardia, not tachycardia like you typically see in bleeding. It's caused by a spinal cord injury above the T6 level. Because of peripheral vasodilation, the patient will actually have warm extremities. Plus, the jugular venous pressure, or JVP, is not elevated. Initial treatment is always fluid resuscitation.
A spinal trauma patient remains hypotensive despite adequate fluid resuscitation. Which drug should be administered? A. Morphine. B. Dopamine. C. Norepinephrine. D. Atropine. E. Double the amount of fluid. The correct answer is C. Norepinephrine. If they're still hypotensive after adequate volume replacement in neurogenic shock, you need vasopressor support to restore vascular tone through alpha-adrenergic vasoconstriction.
Persistent neurogenic shock requires vasopressor therapy. Norepinephrine is strongly preferred here, though phenylephrine is an acceptable alternative. You see, fluids alone simply might not correct vasodilatory shock because the tank is full but the pipes are too wide. Warm peripheries are a classic indicator of a distributive shock state.
In neurogenic shock with a MAP less than 65 millimeters of mercury despite an adequate cardiac output, which drug increases MAP? A. Morphine. B. Dopamine. C. Norepinephrine. D. Atropine. E. Dobutamine. The correct answer is C. Norepinephrine. The primary defect here is a profound loss of vascular tone. Norepinephrine causes potent vasoconstriction and effectively drives that mean arterial pressure right back up.
Target MAP pearls. Your target MAP is greater than or equal to 65. Volume resuscitation must precede vasopressors. Atropine treats bradycardia. It does absolutely nothing for vasodilation. And dobutamine is an inotrope. It mainly increases cardiac contractility, which doesn't fix a vascular tone problem.
A patient has a blood pressure of 70/50, cool extremities, a pulmonary capillary wedge pressure of 18, and a cardiac output of 3 liters per minute. Most likely diagnosis: A. Anaphylactic. B. Hypovolemic. C. Septic. D. Cardiogenic. E. Neurogenic. The correct answer is D. Cardiogenic shock. We're looking at a combination of profoundly decreased cardiac output alongside elevated filling pressures, pointing directly to left ventricular failure.
Cardiogenic shock is defined by low cardiac output plus high pulmonary capillary wedge pressure. The most common cause is an acute myocardial infarction. You'll see elevated jugular venous pressure. Pulmonary edema is very common because fluid is backing up into the lungs. The preferred inotrope to help that failing heart pump is dobutamine. As we wrap up this explainer, I want to leave you with a critical question for both your exams and your clinical practice. Are you treating the numbers on the monitor, or are you ensuring the patient's actual tissue perfusion? Remember, blood pressure is a late sign, oxygen delivery is paramount, and understanding the distinct physiology of each shock state is what truly saves lives. Keep that focused mindset and keep learning.